I just want to welcome all of you to World Coma Day, and thank you very much for being on and having one of our live discussion sessions. My name is Claude Hemphill, and um, you can see Daiwai Olson as well. He's down in his living room, I believe in Dallas, Texas, where it's 2 o'clock in the morning, and on World Coma Day. And Daiwai and I are co-chairs of the Curing Coma Campaign. I'm a neurointensivist at the University of California, San Francisco, and Daiwai is a research professor in nursing and neurology at the University of Texas Southwestern. And what we wanted to do with World Coma Day, this is our fourth World Coma Day. And in prior years, as some of you may know, and maybe all of you have been on prior World Coma Days, we've had 24 hours of programming where we had lectures and shout outs and stories of hope that really went around and were shown as a continuous video loop with moderation. And what we decided to do this year is do it a little bit differently and have a lot of the content be on demand. And so this has been pushed to our YouTube channel so that it can be viewed really anytime and save live sessions for some very specific highlights. And this year, what we wanted to do is have each of the NCS global regional chapters around the world have an opportunity to kind of get together and have a little bit of a Q&A and discussion. And you guys are our first session of the day. So really want to thank Yasser and your entire team for um, uh, getting on. And this really is your time. Now, I am going to say that um, I am an English speaker, and it's fine if you want to speak English or if you want to speak a language that's not English. I will do my best to follow along. But really, the goal is to highlight your chapter here and the interest you might have in Curing Coma Campaign or NCS or neurocritical care or really whatever. So, Yasser, would it be okay if you introduced the folks that are on as panelists right now?
Yeah, so what I'm going to do is I'm going to introduce myself and I'm going to ask everyone to introduce themselves and talk a bit about where they are, especially from a location point of view, and how much they've contributed to neurocritical care and the World Coma Day. So my name is Yasser Abul Hassan. I'm a neurointensivist both in Kuwait University and in Ibn Sina Hospital, where I direct the neuro ICU there. The neuro ICU there has been there for a long period of time, since 83. It developed into a neurocritical care unit probably now, I would say 13 years. It wasn't as formal as it happened in 2012. We have established various programs and MOUs with various ICUs within Kuwait itself. I'm also the chair of the Middle East and Africa Global Partnership within the NCS. And I'm very happy to have this esteemed panelists, group members from our region. So I would invite Dr. Deboo to introduce himself now.
Thank you, Yasser, Claude, Dawai, and for this invitation. It's an honor to be here, I think, on my second one. And by way of introduction, I did my neurocritical care fellowship at the Cleveland Clinic in Ohio. And with esteemed colleagues and founders of the society, I was lucky to undergo that training and then recruited to Cleveland Clinic in Abu Dhabi, UAE, to establish the neuro ICU. Fast forward 8 years later, it's dedicated to now 28 beds. High volume cerebrovascular. We see over 100 of subarachnoid hemorrhage, ICH, and 100 of 200 malignant strokes every year. Fully equipped with 24/7 neuro IR, neurosurgeons. So it's a very, we have high volumes. We see quite a different patient population, which is unique about this country. Demographics, mostly Indian subcontinent and Asian population, and the demographics of our pathologies is quite remarkably different from North America. So I'm enjoying that. And I'm lucky to participate with Yasser for the past many years in the Middle East Africa chapter to grow the awareness of neurocritical care in the region, which is lacking behind. And then through multiple conferences, namely the Emirates Critical Care Conference in Dubai. Yeah, we're trying our best every year through numerous conferences and setups such as this one to raise awareness, especially for the people of this country and the region, to be more akin of various pathologies of neurocritical care. And specifically today, we'll talk about coma and its intricacies in the UAE. So thank you for having me.
Thanks, Jimmy. I would like to ask Abdurrahman Faris to introduce himself, please.
Thank you, Yasser. I'm an internist intensivist. I'm a chair of a department in Amiri Hospital in Kuwait. It's a general intensive care unit. We do get a case mix that is mixed between respiratory, cardiac, some neuro as well, and other organ dysfunction. We see a lot of strokes, post-strokes, hemorrhages, and anything that is not maybe operable that requires a neurosurgical intervention. I thank Yasser for this invite. The whole world of neurocritical care is not my regular forte. I'm more into respiratory and extracorporeal life support. But this is a new interest that we're trying to get into, and I've been the second site for the Compose study here in Kuwait, and hopefully we will be able to increase awareness of the World Coma Day and take it further in Kuwait locally. Thank you, Yasser, again, and the whole panelist.
Thanks, Abdullah. Dr. Umar Ayub, would you like to introduce yourself?
Assalamu alaikum. My name is Umar Ayub. I'm an associate professor of neurology, stroke, and neurocritical care. I was trained at McGill University in 2011, and since I came back, I was deeply involved with the Neurocritical Care Society of Saudi Arabia. We have established the Neurocritical Care Society of Saudi in 2011-12, something like that. And since then, we have been conducting yearly conference with the intensive care unit of Saudi Arabia. Also, I have had the pleasure of establishing few intensive care units across the region, the last of which is a month ago, where I was glad to establish a new neurocritical care unit in one of the private hospitals. It's about a 15-bed unit and fully functional now. I'm really glad to be part of this group, and I thank each one of you for the invite. And hopefully for the attendees, it'll be a fruitful day. Thank you very much.
Thanks, Dr. Ayub. Dr. Sana Al-Khawaja, please introduce yourself.
Hi, good morning, everybody. Thank you very much for the invitation. I am Dr. Sana. I am an intensivist. I have done my fellowship in Canada. I am the Chief of Medical Services for the Center of Excellency, which is including the neurocritical area. So previously we did not have, the main ICU, we are seeing all the cases, as we have very high volume. We are seeing subarachnoid, a lot of intracerebral bleed. Recently, we have opened our stroke unit for the last 3 years. It's an intervention radiology with the intervention radiology as well. And we are planning to open a special ICU for the neurocritical care, where it will be about 10 beds. We have done the full arrangement, and hopefully we'll open it within the coming few months.
Thank you, Dr. Sana. Dr. Abdullah Al-Jadidi, please introduce yourself.
Hi, good morning, everyone. I'm Dr. Abdullah Al-Jadidi. I'm a consultant anesthetist and neurointensivist. I finished my training for anesthesia and ICU in Oman. Then I did my fellowship in neuroanesthesia and neuro-ICU in University of Birmingham, Queen Elizabeth Hospital in United Kingdom. Currently, I'm the director of anesthesia and ICU departments in one of the trauma centers in the country. We have I would say, like the largest ICU in the country. We have like 30 beds ICU, and it is mainly for trauma and neuro cases. When I say neuro, it's like neuromedical and neurosurgical cases. We receive all the patients throughout the country, and also we have a stroke unit in our hospital. We do also like interventional radiological interventions like foiling, ABM embolization, and embolectomies for stroke cases. Thank you, everyone.
Thanks, Dr. Abdullah. Claude, it's all yours now.
Yeah, I mean, this is great, and listening to each of your backgrounds and your interests, I was struck by the diversity of backgrounds, bringing together from anesthesia to neurology to internal medicine. And Daiwai actually posted a question for the panelists and asking, are most of the beds for each of these hospitals, each of your hospitals, housed within ICUs, or are they physically separate wings? You mean like Daiwa, do you mean physically different from the hospital itself, or general ICUs, multidisciplinary ICUs versus individual specialty ICUs?
Yeah, I think what I'm really interested in, and hello everyone, thank you very much for attending. It's an honor to meet some of you virtually. Because my background is nursing, I wonder how many of the staff that you're working with identify as neurocritical care in nursing and physical therapy, occupational therapy, respiratory, where when it's housed within a single ICU, where half of the beds are neurologic and half of the beds are cardiac or something. Yeah, so I see Jimmy Do has commented. So how does that play into when we're teaching people about consciousness and coma in a different way? And I see Jimmy's nodding his head. Maybe there's a better way to explain.
Yeah, I can weigh in. I mean, yeah, look, we're lucky that it is a dedicated separate neuro ICU unit, 28 beds. Medical ICU has its own floor, 28 beds. Cardiac ICU has its own floor, 28 beds. In terms of physicians, we have managed to recruit two board-certified neurointensivists from the U.S., and we had two Palm Critical Care physicians that recently sat for the ABIM Neuro ICU Fellowship board. So that's from a physician standpoint. We have three APPs from the US as well as their Neuro ICU dedicated. So we're fortunate from that. And in terms of nursing, it's a very good point. And then allied health. This is one of the areas, and probably I share this with lots of our colleagues, that you're not fortunate to get like neuro ICU dedicated nursing. Most of the nursing actually in the UAE specifically, they're coming from abroad. And there's not a big amount of nursing school here. So, and when they come mostly say from Asia or Indian subcontinent, not that many have significant neuro ICU experience. So we have to upskill them, bring them up to speed. In terms of neuro ICU, we have education happens at the bedside. And specifically when it comes to disorder of consciousness, nursing, for example, are your eyes and ears, and you have to be mindful that to teach them, for example, as simple as a right MCA hemispheric stroke, when their eyes are closed, that doesn't mean they're comatose. They might have eyelid opening apraxia, all the way to why are they not waking up. So a lot of teaching and the value of all these advanced testing that we do from EEG and MRIs and all that stuff. So that takes a lot. And we're fortunate to have dedicated allied health just for the unit. That helps for the physical therapist and occupational therapist to keep on doing better and better for our stroke patients particularly. So this is kind of the setup and its intricacies in terms of when it comes to our patient care.
Well, probably add to some of that. So, as Jimmy was saying, working within a hospital such as Kuwait, you get to see a cosmopolitan workforce. You can get various manpower and from all the different countries and different backgrounds. Within the neuro ICU that was set up and dedicated to this area, as I mentioned in the 80s, it wasn't formal training for the nurses themselves to be neurointensivists. So in the early part of the 2010s, in 2013 and 14, we dedicated formal training to the nurses because we've recognized at that point is if you don't have formal training, then you might miss on the integral details that you want to pick up when it comes to assessing and managing neurocritical care patients. So that was the baseline of elevating the status of towards a neuro ICU. However, it was recognized that the multidisciplinary team is important, and without having multidisciplinary representation within the round itself and within the weekly meetings and all the different committees, then you cannot approach the patient and address what's critical towards neurocritical care and coma treatment. So that was done over the past year, and we're proud actually to say that we have members from the various teams, including physiotherapists, occupational therapists, nurses, of course, as I mentioned earlier on, clinical pharmacists, respiratory therapists that are part of this. Nutritionists are important too, and they rounded us on a daily basis. So we're able to get that point, and we've done a lot of education dedicated to each of the specialties to address what it means to take care of a neuro-injured patient.
Well, that's great, and I've got a couple of questions. I'm just gonna throw out to the panel and see what you guys think. I don't know if Yasser prepared you guys with these questions or they're new, but there's some of the questions that have come up in just discussions with among the Curing Coma campaign as we've evolved over the last 5 years. One of them came up on a Compose study. Just some of you are investigators in Compose, but just a reminder, Compose is a prospective observational study that's ongoing right now. It's a patient-level study, which is international. It's coordinated out of Baylor University in the U.S. Chetan Rao is the principal investigator. But it arose out of the Curing Coma campaign and is funded by the Neurocritical Care Society and the Neurocritical Care Foundation through the Incline Grant Program. And it seeks to enroll, I believe, about 475 patients who are in coma and prospectively follow them at least to hospital discharge, but for hospitals that are able to follow them longitudinally, trying to get a handle on some trajectory of outcome for patients with coma, and to also help us build our network of sites for future studies. So anyway, that's Compose. And so we were on a Compose investigator call a couple of weeks ago, and the question came up, which I was kind of surprised it was a question, but the question came up, said, in your intensive care unit, do you use the actual word coma or its direct translation into your local language, or do you use a different term, and why or why not? Curious if anybody wants to take that. Do you actually say this patient is in a coma when you're talking to the nurse, talking to the therapist, talking to the family?
Okay, I will start. I mean, in our ICU, usually we said that the patient is not waking up.
Mm-hmm.
We find it's more broad, because if we are saying that the patient is comatose, that means he's really comatose. Sometimes we are not sure if it's related to medication or he might wake up after sometimes. And we feel that if you are telling the nurses and the family that the patient is comatose, it's have a different meaning. That means he's already have a lot of complication. But using the word he's not waking up means that there is more hope, that we are investigating, that we are waiting for the patient to wake up. I find it's more suitable at the beginning till we reach a clear diagnosis.
So it's interesting. I'm gonna just ask a quick follow-up, but then I want others to weigh in. So does that makes it sound like the word coma has a prognostic significance to it, as opposed to just necessarily describing the current state. Is that right? Is that perhaps why that phraseology is preferred?
Yes, yes.
Interesting.
Because it's not, I mean, among the medical staff, we are aware more, but if you are using this word and some of the relatives is there, or some of the nurses, which will pass this message to the relative, it's a prognostic wise. So just using is not waking up, it's more broad.
Interesting.
Yeah, I would echo this point. The word coma in Arabic is غيبوبة, and when you say غيبوبة to someone, to somebody's relative, there is a connotation that it's an extreme state that is not reversible. That the patient will not come out of it, and this will be their state for the rest of their lives if they live. So we tend to shy away from using the word, the Arabic version of it, especially with relatives. Within the healthcare team, with the interprofessional team, it's probably different. But for relatives in general, we tend in our ICU to shy away from using that word.
Yeah, and it's also the same thing with us. I think this is part of our culture, like in Arabic culture. So it's very difficult to say or to tell our people or patients or their relatives that the patient is comatose or in غيبوبة, because the way they receive it, that the patient is fully in coma, fully comatose, that the patient is not responding. And when you say that word, the patient is really in coma, and they see the patient moving, thinking, they're going to come to you. They'd say, oh, see, this patient is not in coma. Why are you saying this? So the way they translate that word is really different. So that's what which is the same thing for us. I mean, we try to avoid that word, especially for relatives. We say simple words like, is still maybe under the effect of anesthetics, maybe under the effect, maybe because of that brain insult, all right, but still not waking up, all right. We don't really say just patient is comatose.
Very interesting. Yeah.
So there was a comment, Claude, about the word, the Arabic word having a deeper sense of permanence, that it's not a reversible condition. Did I hear that correctly? Or can someone explain, like, the development of the word? Is it still from the Greek?
I would ask Dr. Amar Ayub to actually try to tackle that question. Dr. Ayub, are you able to unmute yourself?
Come again? I lost the signal for a second. What was the question? Sorry.
So the meaning of the word coma within the language, with the Arabic language, especially غيبوبة, and the effect of that on society, and is it different when you use the word coma in Arabic, غيبوبة, versus using the word coma itself in English?
Yeah, I think the perception is always different. Let's say in one of the videos that I looked at, when they interviewed people in the street, one of the striking things translating it to the population here in Saudi or in the Arabic population, some people equate coma, when you say غيبوبة, to brain death. So that means maybe they are not going to wake up. Their brain is permanently damaged. There is no hope. There is something extremely, extremely wrong with them. And the possibility of them coming back is almost zero. I think this has changed. Let's say before 10 years, that was even worse. I think it's a little bit better. But again, I think in our let's say, in our community as physicians, we try to shy away. Even for me, let's say, I'm trying also to give examples. When people come to me with epilepsy and they have clear generalized tonic-clonic seizures, and they ask me what is the problem with them. In the first interview, I don't tell them this is صرع. صرع means epilepsy. They just hate that word. So the way I usually tackle it, I say, oh, you have disturbances in your electricity of the brain, like I would say just تشويش بسيط في كهربائيات الدماغ. That's the way I just rephrase some of the words to make sure that they understand what I say, and then to make it easier, and then with time that they accept what is the meaning of it. So I think at the beginning of, or let's say when I'm first saying that they are, let's say, comatose, I'll say they have lost their awareness. They are غائب عن الوعي. That is the word I use, just for them to understand that he's not aware with us, he's not interacting, or she's not interacting. And then with time, it depends on the family, on and also on their understanding, their education. I may go into deeper explanation of what's going on, what is the meaning of coma, if I needed to. I think this is usually the way I do it with every single case, either of coma or any other disease. I think I would just break it down, see their background, and then expand accordingly.
I'll build on what all my colleagues said. We learned that the hard way, as the UAE healthcare is overall has gone on a very steep curve of maturation over the past few years. Even actually brain death concept and law was passed only in 2017. Mm-hmm. And so when most of us came from the US or Europe and we were setting up the hospital and we start seeing our patients, like, to me, it's a learning of any industry across the world. When you want to globalize, you have to adapt to the culture of the people you're dealing with. In the US, families come in with an advance directive and a living will. Your life is easy, and you do comfort care, good discussion, you get it out of the way, everybody's fine and at peace, and families are attuned for that. Here, I'll fast forward to even when you're done with all your investigation, to echo what Dr. Sanan and Abdullah said, and you're sure that the patient has, diffuse brain injury, you cannot take away the culture of hope that the people of the UAE, for example, or this part of the world, they have. No matter how confident you are, most of them, you cannot take away the hope from them. So saying coma, it actually will enrage them a bit. Because to them, you're sentencing them to coma, whereas coming to the whole point of World Coma Day and the future research, what if you're wrong? And probably all of us were surprised with miracle stories when patients come back. We don't see them, right? When you send them to long-term. All of us probably have seen one case of such. So you think twice about committing, but then you rephrase it, as all my colleagues said. Look, now, yeah, I mean, you can scientifically say they're in coma, but it doesn't mean they won't wake up. It's a matter of time. It's a matter of rehabilitation and future testing. So I think the key point I want to highlight is this area is focused on hope, and they tell you flagrantly, you're not God. That's the first sentence. When we first started, we were very direct, as if you're in the US, and we learned it quite the hard way, that first you hear that you're not God. Second, there's always hope. And third, they will tell you, I've heard that one story of someone waking up, and that's the end of the conversation there.
I'll just chip in if I may. This has been actually a learning curve for me. I've gone through various systems of education. I've worked in various places. What I've realized, especially with adopting or being an investigator on Compose within Kuwait, is as soon as we actually agreed on doing Compose, the language within our unit has changed. So yes, what everyone was saying is extremely accurate. However, the step that we took it further is we wanted to establish baseline education with family members of their loved ones who are in coma. Then we actually described what a neuro exam means and what coma means, especially when we come and talk about localization versus extension versus decortication and so on, and no movement within the motor itself. The eyes we talk about, the movement of eyes, but it's what we concentrate on the most is motor movement and best motor movement. And then we actually say from the outgo is coma might be reversible, and that's what we're there to aim for. Coma is an acceptable terminology within medicine. It had previous connotations which were negative. However, what we're working on and what we're striving to do is to further understand it, to do the research on it, and to try to impose the concept of hope. And this is over the past few months that we've been using this clearly within not just the healthcare setting within our staff, but also with family members upon discussions. And having the regular discussion with family members actually made the concept acceptable in that immediate setting. However, when you actually heard what Abdullah and Sana and Omar and Abdulrahman and Jimmy were saying is, when this evolves outside that immediate setting, then perception does change. So I think it's part of our education to, or part of our commitment to society from a social justice point of view, is to explain coma and to actually introduce the part that partially, or there are a number of patients that might recover out of coma.
It's really interesting to hear this and and learn from you, because I mean, this is why we have the Curing Coma campaign as a worldwide initiative, and so key to have you guys here on World Coma Day. I want to ask a question that maybe follows from that a little bit. So I'll preface it a little by saying, at the beginning of the Curing Coma campaign, when we really just started, it arose out of a scientific strategic planning meeting that Neurocritical Care Society had in 2018 that was born out of the frustration of many negative clinical trials and the lack of let's say evidence-based treatments for many of the conditions that we manage, and we are aware of that. We're all aware of that. And so it was a scientific initiative, and one of the first questions was, what are we going to call this? And there were some folks that said, well, we've got to call this a mechanistic approach to understanding consciousness and developing targeted interventions. So we've got to call this something like something like that. And you're probably familiar with, I certainly hear about the concept of the elevator pitch. It's like, by the time you get those words out, the elevator door is closed and people have stopped listening. We said, we've got to call it something that is positive and inspires. And we said, we're going to call it the Curing Coma Campaign. And we got a little bit of pushback from some people, said, that's not rigorous enough, or you're really going to cure coma. And then we created the tagline called Awakening Hope. And we did that purposefully, and I think with the recognition of the challenge of that. So we've purposely had that the name of the campaign, had that as the tagline. And I'm wondering, have you had any feedback from your collaborating ICU doctors or nurses regarding the Curing Coma campaign, or the term Awakening Hope, or is there skepticism when that terminology is used? And I'm really curious to given the discussion that just went forward, hear your thoughts on that.
I can start.
I
I think
sure,
more or
go.
less skepticism. I would think so. The one way I thought about it, why? I always think about it, why? And partly I ask myself, what you all ask ourselves for certain cases, like what is going to happen with them when you discharge them, right? And this is where sometimes, although I don't miss my neurology clinic days, but this is sometimes where I feel like a post-ICU discharge follow-up will help and will teach us more about when we are really hopeful and when we are really treating to patient and to what point. So I believe the skepticism really arises by the lack of follow-up and by our fragility or inability to answer that question. What's going to happen? When are they going to wake up? In the cases there's no uncertain, you're not certain of, like now as we speak in the unit, we have 2 NMDA encephalitis ladies in the early 30s, and we threw everything at them. It's been few months, even we removed their ovaries, etc. And the brain still structures, it's okay, and there's no seizures. They have movement disorders, chorea, and all that stuff, but we're going to discharge them soon. But what's going to happen with them? And these are young. You cannot bet against a young patient with a structurally normal brain. So I believe the skepticism, but once the staff has been seeing them for a few months, right? Same state, you cannot buy hope. You become more skeptic because they've been with us for a few months. So this is where the follow-up is crucial, because then the next case, if they wake up, even to any extent, they'll be less skeptic. So I believe that exposure for after ICU discharge will change our mindset when we have them as we go in the unit.
Yeah, I agree wholeheartedly here. I trained in Toronto for my critical care fellowship, and what struck me the most is working with Margaret Herridge. I don't know whether you guys know her or not. She's one of the most advocates for long-term follow-up post-ICU discharge, and had published so much in post-ARDS and sepsis outcomes outcome up to 10 years even. So one of the things that I brought back to the unit here is a post-critical care follow-up clinic, and it changed the perspective of the staff. We tend to bring those patients to the clinic, from whether it's a neuro or others, and we introduce them back to the unit, to the staff themselves, whether the nurses or other interprofessional team, to see the evolution of what happened to these patients once they leave the unit. Sometimes we discharge, as I had mentioned, comatose people or those with mechanical ventilation dependency, etc. And then you see them after 6 months or a year where they're completely different and back to almost their normal self. So that's added a huge perspective to staff and changes the, even the day-to-day management of them and igniting hope in things that we do.
That's interesting. Abdullah, I think you were about to say something at the beginning.
Yeah, I mean, this guy called World Coma Day. Actually, like myself, I didn't know about it till we had the recent meeting with Dr. Yasser.
Yeah,
and he was like telling us about this awakening coma and awakening hope and coma day. We were like, what is it exactly about? Then I tried to explore more about it. Then I found that it was started in 2018 or 2019. Now, when I started advertising for this day in my unit, and I was like also advertising in social media. So our people came like, do we have a day for coma? Do these people wake up? And I said, yeah, there are stories. I mean, where people like our patients, they woke up. They said, yeah, we hear those stories, but is it true?
Yeah.
And I said, that the problem that with us, and those questions came also from public, actually, from people that I know, but they are not in healthcare system. They are not professional in healthcare. They were like, they said, see, these people may wake up. So what we see like in movies, in drama, it might be true. I said, yeah, there are like stories where the problem with us and our people, our colleagues in the unit, we don't follow up with these patients. Once they are discharged from ICU, we may not really know what is happening with them. So we have like a boy, it's almost now He was with us maybe for 3 years. And to the extent we needed, we decided to do brain stem test. We did, it wasn't conclusive. We did the CT angio and perfusion. It wasn't also conclusive. We trichostomized this patient. We discharged this patient. And now for almost 5 years, he's living with his family, still in a coma status, but still like, that hope with the family is there.
This is very interesting. Yeah. Anybody else have any comments about that? So I'm curious, in your region, how important or valuable is public outreach or public support of an initiative like this, as opposed to primarily it being something that's scientific or clinical within hospitals? Is public outreach something that is a target or a goal, or not so much? I'm just curious. It's something we're trying to figure out more of in the U.S. regarding the Curing Coma campaign.
If you take it in general, let's say when the decision that we are talking about, let's say if we want to take just in general any medical subject, it's something that's not going to affect, let's say, their practices or their religion or their interaction or their family values or something valuable within the culture, then they will not care. So they will say, okay, we'll follow physicians. They will not be outraged by any change, and they will just follow through. As simple as, let's say, treating pneumonia, they will just follow what you are saying. But when it comes to something really critical, and I always take brain death as an example because always huge debate in the public about accepting it or rejecting it, and also they have their skepticism about its presence, and also about if religion allow it or not. So in that matter, I think we have to be very careful in what we advertise, what we initiate, and what we do, and we take it extremely carefully, not to play on anybody's nerves, and make sure that we are aligned with the population and also with everybody else, that what we do is aligned with what they are thinking. And also, let's say we push it through to make sure that we take their blessings some way or another. I think in coma, I'm not sure if the public here have very strong stand on what we do when it comes to coma, because it's not really equal to brain death. So I'm not 100% sure. I'm not sure what is the standpoint of the public in this point. If anybody can add to that point.
I would add. Go ahead, Sam.
Yeah, I think public awareness is very important. And again, I will take the example of brain dead, as Dr. Omar said. It was very interesting that before 4 or 5 months, we have a big debate about the brain dead. We had a meeting. It was organized by some private people that it was involved, the physician plus some people from the community plus some religious people, which is controlling the other people. I mean, religious in our country is something is very important. Sometimes these what we call them shuyukh ad-din, they can influence the other people. So if we can if we can give our idea to these people, then they can influence the other community in general. So in that time, I would discover that most of our people, they don't understand even the concept of a brain dead. They are completely against the idea itself. They are thinking that this is, the coma and the brain dead, it's all of them something related to God. Maybe because they are not seeing the patient is moving, maybe they are not seeing it take a long time, and sometimes we cannot explain it. We don't have a very clear explanation. So that's why they think it's all related to God. So I think involving of these people, the religious people, it will make a difference in understanding that what's happening.
Yeah, I want to echo most of what it's just said. I guess it's a bit at least I'll speak of UAE and Abu Dhabi. There's a lot of public awareness to be made. It's healthcare education for the people is key. They haven't been paying attention to the basics of their needs, fundamentals we're talking about, let alone, so it's usually challenging for us when it's World Stroke Day to start doing this awareness and then going to the malls and these checks. So explaining high level scientific or medical conditions, only the people that have been through this experience for their loved one, till you can engage with them. And then there is what I echo, like even actually in a couple of weeks, what Sanat was saying, one of our physicians, we will be going to the Emirates Fatwa Council and 50 religious attendees. We will be sitting with them, and they asked us to talk about brain death. So there is a need for awareness. At the highest level of the country, they're encouraging all healthcare facilities to do this outreach. At some point, we will get there. I think the punchline is, your punchline of awakening hope will be more intriguing, because simple language, and especially for the people that have been affected or know someone that is not waking up, they will be intrigued to know more about what is it about. That will probably work, but there's a lack of years of healthcare. We're behind Western, like America, in terms of healthcare education, which is needed for the people of the UAE.
So if I can chip in there. So yes, it's important. That's the simple answer to Claude's question. The community has to be aware of what coma is, but what I am also interested in is not just to keep on a message of hope, but actually give action numbers when it comes to what does coma mean, what are the etiologies that are associated with coma, which etiologies are reversible, and to be transparent to the community, to stakeholders, to the public, and so on, with descriptions of each of the entities and etiologies that lead to coma. A vascular coma is not like a medical coma. It's not like a diabetic ketoacidosis type of coma. It's not like a coma associated with hyperglycemia. These are various entities. What we see in a vascular unit, in a neuro ICU that gets to see vascular and tumors of the brain, is different than what you would see in the medical. However, all of these come under coma. The public has to be aware. They have to understand the language that we talk about. So yes, we need to get there. However, we need to get further data to present to the public that is in a language which is understandable to all.
So we got about 10 minutes left on our hour. Everybody gets a magic wand, and each of the panelists is going to have to weigh in. And so with your magic wand, you get to create or enable one single advance in the care of patients with coma and disorders of consciousness for 10 years from now. So what would it be? If you could have one single advance in the care of patients with coma, disorder of consciousness, that 10 years from now it exists, what is it? I'm gonna call on folks. You don't have to be long. You don't even have to explain yourself. Just say what it is. You can if you want. All right, Jimmy, you got 10 years from now? If this is there, that was a good advance. That's what I wanted.
I'm hopeful because a lot of investigators are trying is non-invasive continuous monitoring, getting in the head of the patient, especially the comatose one, that the brain looks okay, but they're just not waking up. And we're postulating that they have a little hypoxic injury here, or, and then we keep on doing these spot EEGs or 24 hours EEG every day, a functional MRI. How can you justify it? You want to discharge the patient. I want to get in their head 24 hours non-invasively in a cost-effective way to understand truly, are they covert consciousness or not? This
Okay.
subset of patients that these are the ones, and I know there's ongoing TCD, the portable one, the EEG. I feel technology is gonna get there, put that on their head and learn from them real time. That's what I wish to see, to be honest.
So non-invasive, practical implementation of covert consciousness detection. All right. Who's next?
I would say.
All right.
Now, AI, artificial intelligence, is there in everything. So who knows, in 10 years, they might have something for us, for those comatose patients. Hopefully, I don't know how to explain it, but this world now, it's going so fast. I mean, you just, every day we come up with a new invention, new things and the like, and who knows?
So AI detection of coma etiology and mechanism.
Yeah.
All right. Sana, what's your? Oh, you're on mute. You're on mute.
Yeah, I would copy Jimmy. I'm thinking about something like the functional MRI or something which is non-invasive and cost-effective to know what's happening inside their brain. Are they awake? Are they listening to us? Are they listening to their family? I would like to know what's happening in their brain.
Great. Omar?
Yeah, I think you said it's a magic wand, so we go
Yep,
for them.
absolutely. Absolutely.
I wish we had something that would pick it up extremely early and we prevent coma right from the beginning. That's my.
That's interesting. Okay, yeah.
Sorry, hey, Claude. Omar, do you mean detecting risk factors or detecting onset?
No, detecting onset so we can immediately prevent it.
So really hyper acute diagnostics. Wow, interesting. Abdul Rahman, what's coming at it from an internist
From a
intensive?
general
What's
intensivist, yeah.
the general
So-
intensivist want 10 years from now in these patients?
Maybe you know, whatever has been mentioned is great, but to echo what's happening in the world of ARDS and sepsis, you know, patient-centered kind of interventions, or you know, phenotypic, because as Yasser mentioned, there are several causes for coma, and each one manifests differently and progress differently. So is there any, you know, to have an easy tool at the bedside to phenotypically divide patients so we can manage them appropriately, and having more therapeutics, you know, specific therapeutics that could reverse coma from whatever etiology rapidly, rather than waiting for a prolonged period of time.
So targeted therapeutics based on specific phenotypes. You know, it's interesting that you said that. One of the term we're using in the Curing Coma campaign is endotype, partly because we feel like you know, coma is by its very nature a type of phenotype, but endotype is perhaps describing the underlying mechanism or neural circuitry or so forth of it, and that very interesting. So targeted therapeutic. I'm gonna say that you said targeted therapeutics based on endotype.
Sure.
All right, Yasser, what's your magic wand?
So it's interesting to actually follow up on what most of my colleagues are saying, but to go for a different angle, neurostimulation. That's how I would leave it at. Better neurostimulation mechanisms.
You know, I put that out there because I think I think it's very important that we uh, it's okay to think boldly and creatively. We set out a 10-year roadmap at the beginning of the Curing Coma campaign, thinking that it was 10 years. Oh my goodness. And yet we're 4.5 years in, and this is challenging. This may be a long-term thing, but it's 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 been absolutely wonderful to, I mean, the two aims of the Curing Coma campaign broadly are advance the science and build a community. And it's been absolutely wonderful to see how we're moving on this, but it is a grand challenge. There's no doubt. Um, so one of the things that we're really pleased about the way we've organized World Coma Day this year is the on-demand videos. So hopefully you've had the opportunity to watch some of the videos, and we'll pass this on to your bedside nurses, to your colleagues in the ICU, to patients and families if you think it's appropriate, because we want to make these accessible, and they range from didactic lectures to stories of hope. I looked just before we got on, and the video so far that has had the most views is the dog that is supporting the Curing Coma campaign. So I don't know if that's telling us anything, but that's I guess dog videos are a hit. But I would just I want to personally thank all of you for being on this. I have learned a tremendous amount, and it's been very enjoyable. And to be able to highlight the Middle East uh, chapter and your work with NCS and the Curing Coma campaign, it's really been an honor. Yasser, anything else we should address before we close?
I would like to thank everyone for being part of the session. That was actually impressive to see the various panelists, esteemed panelists, agreeing on being part of this. I know it's probably uncomfortable subject to talk about. However, what I'm guessing that I would like to bet on is to find this discussion easing among not just the healthcare professions within the Middle East, but also that would translate to the community itself, and to unstigmatize the word coma and to add some realistic hope to it.
Well, I think that's a great way to conclude. So thank all of you, and enjoy the rest of World Coma Day. Take care.
Thank you all. See you. Bye-bye.
Yeah.
Thank you very much.
Bye-bye.
Nice meeting everybody.
Absolutely.